Next on the mic, we have Dr. Vivek Nambiar. He's completed his graduation from Bombay University, and he has a fellowship in stroke and vascular neurology from the University of Calgary. He currently heads the Stroke Division on the Department of Neurology in AMRITA Institute of Medical Sciences. He is also a recipient of the famous Paul Dudley White International Scholar Award, which is given by the American Heart Association. He also has 30 plus publications in both national and international journals. Over to you, Vivek, sir.
A very good morning to all. First of all, I thank Dr. M.G.K. Pillai for giving me this opportunity. And so this rings in brain, an easy approach. So this is a rather a radiological topic, but there are a lot of clinical scenarios involved in routine practice. So we'll start with a case scenario. So this is a 42-year-old man. He had got subacute headache for 4 weeks, and he had mild left hemiparesis for last 5 days, but he got improved, but the headache persisted. So he went to a hospital where CT scan was taken. There was a hypodense lesion with some hypertensity and with ring enhancement. So he was referred for neurosurgery for biopsy. So this is a very common scenario because patient will come with various neurological issues, and we will take a CT scan at random, and because we suspect something organic in the brain, so we see a lesion like this. And so how to go ahead with this type of lesion? Is it because in the situation patient is improving, is it important to confirm, or shall we take another imaging, or the patient would be referred for further intervention? So this patient has undergone a stereotactic biopsy from the lesion that was a subacute infarct. So this type of situation can arise if we had better imaging and better thinking about the diagnosis. We could have avoided this biopsy. However, it was conclusive that it was an infarction. So why this ring enhancing lesion happened? So what are the causes of enhancement? So enhancement means we give contrast, the IV contrast, and then the brain would be seen in a different way because of the uptake of the contrast. So what are the different types of enhancement, and what are the causes of the enhancement? So there is something in the interstitial enhancement. So we know that the brain is protected from chemicals and outside materials by blood-brain barrier. And when the blood-brain barrier breaks down or there is increased permeability, there can be a outside extravasation of the materials in the circulation. So that can lead to the contrast can extravasate, which will lead to interstitial enhancement. So it is outside the circulation. So, but we can also see extra intravascular enhancement where we would see lot of contrast uptake, but this uptake would be due to the increased blood supply. So you may see there's a lot of vessels you will be seeing as like enhancement, but it is actually only intravascular enhancement. So there will be increased vascularity or there is vasodilation. So sometimes we will see extra parenchymal enhancement. That means it is not inside the parenchyma, but in the meninges. So you can see thickening of the meninge with meningeal layer with enhancement. So new blood vessels, active inflammation, cerebral ischemia, and pressure overload can produce alterations in the permeability of blood-brain barrier and can cause enhancement. So we can see different type of enhancement. Nodular enhancement here, like where you get a meningeal deposits of nodular secondaries here, or you can have patchy enhancement, or you can have ring-like enhancement. This is our focus of discussion, ring-like enhancement, or this is actually a large glioblastoma lesion with irregular enhancement. So we'll come to that later. So it can be pachymeningeal enhancement, or it could be subarachnoid enhancement. So this could be thin linear enhancement. Like you can see here, the pile layer or arachnoid pile layer is involved rather than the dural layer. So dural enhancement is outside, and the pile enhancement can be into the sulci. So this is one of the type of special enhancement which would be seen in meningitis. So you can see meningitis, you can see this type of pile subarachnoid enhancement. So this is a type of unilateral, that means a focal lesion like a deposit disease, like neurosarcoidosis, an infiltrating disease, or IgG related meningitis. So that could be focal. So similar type of enhancement, but focal. Here you can see diffuse bilateral, thick, lumpy nodular enhancement. This is seen with carcinomatous meningitis. So it's very much infiltrating and spreading disease with a lot of vascularity that lead to increased enhancement in this. So we have complete and incomplete ring enhancement pattern. I told you about the dural based enhancement. This is a meningioma. We can see the dura here, and there is a dural tail, and there is an enhancement lesion. So this is a meningioma. This is a dural tail. And then we have dural arachnoid enhancement. You can see those coming down to different part of the layers. And your pia arachnoid means it will be going into the deeper into the sulci. So there'll be gyral enhancement exactly over the gyrae only, usually seen with subacute infarct. And we can have smooth ring enhancement, especially in the abscess. Irregular ring, we'll come to that in different slides. So this is something cyst-like enhancement with nodularity. This is due to the pilocytic astrocytoma in the cerebellum. So we have open ring enhancement where we get in demyelination. We'll come to that later. So this is cerebral cyst with a nodule, especially smaller ones, Colex and the Neurocysticercosis. And we have thin periventricular enhancement in lymphoma, thick irregular periventricular enhancement again in lymphoma. So this is a classical example of a brain abscess where there is a thin layer of enhancement and there's some perilesional edema here. So this is the pile arachnoid enhancement where the enhancement engages into the smaller sulci. So that is what pile arachnoid enhancement is. So gyriform enhancement usually we see in subacute infarct. You can see the gyrae only enhancing because of the blood-brain barrier will be lost in this area. You can see this type of enhancement. Also, in this situation, actually we have bilateral gyriform enhancement in the temporal lobe. This is due to the encephalitis. So encephalitis and subacute infarct can produce enhancement in this pattern. So this is the common type of enhancement seen with the herpes encephalitis. But if it is unilateral and focal, we would think about subacute infarct. So this is another type of same type of enhancement due to subacute infarction. So pachymeningeal enhancement, this is one thing where you will see severe dural enhancement, which is due to usually either due to the intracranial hypotension, where there will be stretching of the dural layers and there will be more enhancement. So this you can see in the MRI, you can see that enhancement only in the dura rather than into the sulci of the sulci and gyrae. You're not seeing that. So this outside, that is the dural enhancement. So what are the common cause of ring enhancing lesion? There is an acronym called magical doctor. So metastasis, we know metastasis produces a ring enhancing lesion. Abscess, we have mentioned about abscess, glioblastoma multiforme, that is the primary brain tumor, high grade astrocytoma. Infarct in the subacute phase will have, and also contusion, that's cerebritis. AV malformation, it's like different type of AV malformations. Lymphoma, we know it's an enhancing lesion. Demyelinating lesion like multiple sclerosis or tumefactive demyelination, and also radiation necrosis, also resolving hematoma. So these two situations are tricky because radiation necrosis sometimes get confused with tumor recurrence in a patient who had surgery and radiation for glioblastoma. So resolving hematoma is also a tricky thing. When somebody with a hematoma, intracerebral hemorrhage, come for a review and complains of headache, we think about recurrent hemorrhage. So we take a CT scan, we would be seeing a ring enhancing lesion, so which may mimic a tumor. So this is a resolving hematoma. So this is the acronym for the cause of ring enhancing lesions. So how will you approach when you see a ring enhancing lesion? So we should have a clinical approach because we are not seeing the scan alone. We are seeing patients and their clinical presentation. What are their background? How is the headache? What are the other symptoms? So we have a lot of radiological clues on which we will be trying to look into more, and also pathological confirmation in selected situations. We would not go for brain biopsy all the time. We will try to utilize these two approaches, clinical approach and radiological clues, to get into a conclusion, and then we'll give adequate treatment. So generally we'll classify them into immunosuppressed patient or immunocompetent patients with or without systemic disease, systemic symptoms and signs. So this is just See, this is a patient. In this, if this patient had non-immunocompetent patient with some history of heart disease and presenting with headache and hemiparesis on the right side, the aphasia. So this is a case. You can see there is a thin rim of T2 hypo intensity with inside hyperintensity. You can see that this is T2 MRI. You can see the edema around the lesion, and also there is T2 hyperintensity inside. On contrast, there is a ring enhancement, and and also the CT. You can see there is a this actually forms abscess. This because a smooth layer is due to the granulation tissue formation, because inside there is a necrosed tissue. You can see restricted diffusion. So the restricted diffusion and ring enhancement suggest either it's an abscess or it could be a high grade glioma. So here, if the patient is having any symptoms of fever, headache, and any other propensity for systemic infection, more likely to be brain abscess. So the brain abscess will be the first diagnosis. So we can sometimes plain CT will show this type of hypodensity inside peripheral rim of hyperdensity, and there can be daughter abscesses. So we have T1, there is core slightly hyperintense, and GADO there will be ring enhancement. You can see bright restricted diffusion, and there will be, if you do the spectroscopy, you can see lactate and lipid amino acid peaks. So same thing, we can have these type of peaks. You can see the rim here, very clear cut rim, because this is smooth because it is actually a wall formed by the granulation tissue, and it's very clear, it is demarcated, and you can see the perilesional edema. So here, similarly, you can see if this patient had history of multiple sclerosis, stop treatment, and coming with a new lesion, new symptoms, and you take a T1 with GADO, you can see some enhancement, 2 rings. So rings, these rings are open towards the cortex. This is called open ring configuration. So this type of enhancement is seen with the tumefactory demyelination. You can see the restricted diffusion in this, but you can see the clearly open ring towards the cortex. So similarly, this is pilocytic astrocytoma, where you can have a cyst secreting portion and a partial enhancement of the wall. It's not fully, it's because of the high content of fluid. It is not completely enhancing. However, there is areas where there is tumor activity. Those areas will be showing enhancement. So this is a incomplete ring configuration with cystic lesion, pilocytic astrocytoma, and this is open ring, most common form where there is tumefactory demyelination. So when you get immunocompromised patient, for example, this is a patient with HIV and patient had multiple nodular lesions. So this is tuberculoma. But however, this can happen in immunocompetent patient as well. But if this type of thing lesion happen in a patient, this tuberculous abscess, biopsy proven, you can see the tuberculous abscess with the vessel wall showing infiltrates. So basically, this is tuberculous abscess where there could be systemic symptoms. Usually, it will happen with immunosuppressed patients, but these multiple tuberculomas can happen in immunocompetent patients as well. So simple approach would be, if you have immunosuppressed multiple lesion, tuberculoma is a possibility, fungal abscess. One thing is there, in immunocompromised patient or immunocompetent patients, those things which are spreading to the brain through the systemic circulation would be more common in the gray-white junction rather than in the cortex or very deep. So if the patient is having multiple ring enhancing lesions, it could be tuberculoma, fungal abscess, pyogenic abscess, because usually pyogenic abscess will be single, but there could be daughter abscess, and lymphoma. So immunosuppressed patient with single, we have to first consider toxoplasma, and then only we will consider other differentials, lymphoma and tuberculous abscess. So if there is an immunocompetent patient, deep white matter ring enhancing lesion should be glioblastoma multiforme. We have shown that, and lymphoma can involve the corpus callosum, because they are not exactly deep. They can happen in the white matter usually, especially between the hemispheres. So it will be callosum involvement. So lymphoma can involve the corpus callosum. And if there are multiple, we have to consider endocarditis. Endocarditis, again, the abscess will be in the gray-white junction. So then we have to look for systemic symptoms like endocarditis. Patient will have, being unwell, fever, body ache, systemic symptoms, and then they will develop these brain symptoms. So that is endocarditis. And tuberculosis we know, and systemic fungal infection, propensity for fungal infection, and sometimes patient may be on immunosuppressive medications, or patient be having a malignancy. So whole body PET scan will help us to identify uncover the hidden infections like a subdiaphragmatic abscess, a pelvic abscess, or other thing. And MR spectroscopy will give us an idea about the content. So this is the one question, like, so what is this ring enhancing lesion in an immunocompetent male with no systemic symptoms? So look at this lesion, what it could be. So this is deep. So what about the ring? Ring is very shaggy, very irregular, and there is perilesional edema, and it is quite deep. So what will be the differential? One differential would be mostly GBM, because it is deep. It is not causing any systemic symptom. It is deep in the white matter, and there's irregular enhancement. Suppose it is regular enhancement, and with this much of edema, it could be brain abscess. So same thing, glioblastoma multiforme, irregular, shaggy inside, thick variable enhancement, complex, sometimes multilocular, lot of vasogenic edema, variable rim on T2 weighted, and increased diffusion. Restricted diffusion will be there. So this is the necrosis inside the what. So these are the, so this is brain abscess. You can see the regular one. You can see very deep. This is the glioblastoma multiforme, and this is pilocytic astrocytoma with incomplete ring. Here you can see the multiple sclerosis with the tumefactory demyelination. You can see the outside open ring. So now this is this is actually the GBM with the necrosis versus abscess. You can see the difference. The walls are smooth here, but it is irregular. You can see daughter lesions here, but only one lesion here. So neurocysticercosis, another differential. Neurocysticercosis is a very common differential outside Kerala because of the high prevalence of this lesion. And you can see there are several stages. Vesicular means you can see a small lesion, and inside you can see small scolex-like thing, that will be vesicular. Then colloid vesicular would be a little bit more of a hyper intensity in the T2. And the granular nodular means there will be edema like this, and there are multiple lesions. And nodular calcified lesion is the end stage lesion. So this is a 60-year-old lady with who is a diabetic with recent onset ataxia. So what is this differential diagnosis of this ring enhancing lesion? So this is a very common thing, especially in the diabetic with the history of TB or without TB. We can simply say this is a multiple loculated ring enhancing lesion. Usual differential is actually tuberculoma, multiple tubercular granuloma. So perfusion and spectroscopy can help in the ring enhancing lesion, like either perfusion could be the ASL perfusion or gadolinium perfusion. Like we can see different peaks like choline peak, NS or creatine peak or other amino acid peak. We'll come to that later. So tumefactive demyelination, I told you this is the ring enhancement. There is an outside open ring. So this is incomplete ring, very clear. So you can see in the MR spectroscopy, you can see the high choline creatine ratio, and it can mimic a tumor but you can see this is incomplete enhancement. So one important thing is there is no significant perilesional edema. There is no perilesional edema around the demyelination, not much. But in this case, there is some perilesional edema as well. So this is a tumefactory demyelination where you can see the choline peak, and also after treatment, you can see it has completely resolved with a steroid treatment. So in an HIV negative patients, multiple ring enhancing lesions in HIV negative patients, if the lesion size is small, less than 5 millimeter, 5 to 10 millimeter, less than that size, you can take an X-ray chest. If X-ray chest abnormal, if the miliary shadow, it is tuberculoma. Lung cancer, like cannonballs, it could be metastasis. Hilar shadows, you should suspect sarcoidosis. And if there's pneumonia or other systemic infection, you have to suspect abscess. If the X-ray chest is normal, we have to go with CSF because these are multiple small lesions. You have to look for ELISA for neurocysticercosis positive. It is neurocysticercosis. VDRL, it is neurosyphilis. If there is TB meningitis picture with ADA positive, lymphocyte count, high protein, you have to suspect tuberculoma. And if there are fungal FA or cryptococcal or other aspergillus positive, you have to think about fungal granuloma. If diagnosis is not established, you have to go for a biopsy, cytostatic biopsy. If there are multiple ring enhancing lesions in the HIV negative patients are large, you have to suspect abscess, metastasis, glioma, or tumefactive MS. We have told how to differentiate all these things. In HIV positive patients, mostly it is toxoplasma. So we give empirical therapy we try to diagnose it by toxoplasma serology, and even if negative, we'll give toxoplasma treatment. We'll look for response, and if it is not responding to treatment, then we'll go for biopsy. It could be lymphoma, primary CNS lymphoma in HIV patients, or tuberculoma or fungal. So MR diffusion, MR perfusion, MR spectroscopy, all these things can be useful. Also PET scan, they allow us to know about the features, further features without doing biopsy. So cerebral abscess, it shows that hyperintense signal on diffusion weighted images and hypointense signal on ADC. So that is important to identify the restricted diffusion pattern. And pus is associated. Why? Because there is more cellularity and high viscosity inside the pus. So the hydrogen, the proton molecules are not moving. So that will be restricted diffusion. But in cystic brain tumors, we are not able to see the restricted diffusion. So perfusion, as you know, the secondaries, the metastatic lesions and primary gliomas will have more perfusion. So that will help us to identify. Spectroscopy will have like colon peak in the tumor, and amino acid peak in the abscesses, lactate and succinate peak in the parasitic cyst, and lipid peak in the tuberculoma. So these different type of peaks in the spectroscopy will help us to identify the type of lesion. So tuberculoma, show lipid peak. That's a very important point. And in demyelinating disorder, we can see glutamate or glutamine peaks. So all these peaks in the spectroscopy may give us a clue. So where you do brain biopsy for these patients. So we will try to avoid brain biopsy with the radiological approach and clinical approach. But however, sometimes it will be very difficult. Patient may not respond. But whenever there is a non-responsive lesions, we have to go for brain biopsy, because it is well proved that brain biopsy is not that dangerous. Like the mortality of brain biopsy in large series from Mayo Clinic is not very high. It is very comparable. So the outcome can be much well improved by doing a brain biopsy. So biopsy of undiagnosed multiple ring enhancing lesion should preferably performed with stereotacty with a minimal tissue injury. So this is well possible. So especially in HIV patients, the American Academy suggests to do ring biopsy for negative toxoplasma serology patients, because if it is negative for toxoplasma, it could be lymphoma, tuberculoma, or fungus, and we have to identify them and treat accordingly. So we'll carry on with certain rules of thumb. So if there is a nodular lesion, if there is not thickened, nodular lesions favors neoplasm. So if there's an enhancement which is a nodular pattern, think about neoplasm. If there is thin regular enhancement in the ring, we have to think about abscess. If there is an incomplete ring with open towards a cortex, it favors demyelination. So if there is low T2 signals, it favors abscess, and restricted diffusion, usually GBM, demyelination, or an abscess. So if you look at the edema, extensive edema suggests abscess or neoplasm. So if there is extensive edema, there are two possibilities. One is the edema, one is the abscess, other is the neoplasm. And the neoplasm we can identify by perfusion when there is a high hyperperfusion of that area. So central fluid content, if there is a central fluid content and restricted diffusion, it is abscess. If no restricted diffusion, there is a tumor with a central necrotic content. Number of lesions, we have mentioned about number of lesions. So similar sized rounded lesions at gray white junction favors metastasis or abscesses. Irregular mass with adjacent secondary lesion suggest GBM with edema. Small lesions less than 2 cm with a thin wall, especially if other calcific foci are present, suggest neurocysticercosis. So in conclusion, multiple ring enhancing lesions are commonly encountered neuroimaging abnormality. Distinguishing between neoplastic and non-neoplastic etiology is extremely important for planning the treatment. Many features of the lesion as well as clinical presentation and patient demographics need to be taken together to help to narrow the differentials. Thank you.
Thank you, sir, for that wonderful eye-opening presentation. So we actually, I had a few doubts, sir. So if you want to differentiate neurocysticercosis and tuberculosis, many times us physicians come to this confusion when we see multiple ring enhancing lesions in the brain. Is this tuberculosis or is this neurocysticercosis, especially immunocompetent individuals? So how do we go about differentiating that, and whether there's any role for Mantoux test, sir, in when we are suspecting a tuberculoma in the brain, sir?
Yeah, definitely yes. So, I mean, this is not a single test which is proving it unless you do biopsy. So this is actually corroborative evidence. Like if when the patient is having multiple, when some immunocompetent patient shows multiple tuberculomas, usually there will be evidence of systemic tuberculosis. But in case of immunosuppressed patient, it can have everything. But however, generally in immunosuppressed patient, neurocysticercosis will not be producing that much immune response. So the lesions may not be having multiple stages. Only calcified lesions may be seen. But it is important to do all the corroborative tests unless you do a biopsy. If you're taking decision without a biopsy or without a tissue diagnosis, means like if we have a Mando test or a lymph node with in the neck with the TB positive or other culture positive and all, then it should be better. But if you are not taking any tissue, it will be better to do all the corroborative tests, because in many of the series when we in CMEs where many people are involved, they also see the patient with, they think it is a tumor factor demyelination. They take the biopsy, it is a lymphoma. They think clinically or radiologically, they think it is a lymphoma. They take the biopsy, it's tumor factor demyelination. So we should be extremely careful while taking final decision. One of the thing is in case of neurocysticercosis and other thing, we can have a therapeutic trial. A therapeutic trial may be helpful, but however, especially in immunosuppressed patient, when there is no toxoplasma, no response to toxoplasma, then it is better to take biopsy. So Mando test is, of course, it is useful, but immunosuppressed patients, depending upon their CD4 cell count and all, their Mando test may be or may not be positive. So unless unlike immunocompetent and immunosuppressed patients, it is difficult to do without biopsy.
Sir, and any role for the empirical ETT and follow-up MRIs like 3 months later, 6 months later, if we are starting on a patient with suspected tuberculosis, any role?
Yeah, absolutely. Absolutely. This is what we used to practice in real life, even though we would say biopsy many of the time. As I mentioned, the biopsy is actually not that much risky. Biopsy can be done and it will give us a lot of comfort and confidence to treat the patient. But however, most of the time, the family and the patient may not be willing for a biopsy. That is one of the problems. So this biopsy is not a stereotactic biopsy of the mass will settle the issue. But many of the time, family will be afraid to undergo GA and do a stereotactic biopsy. So in fact, we have very good facility to do robotic biopsy where the damage will be much less and the side effects are much less. But empirical treatment, of course, empirical treatment is recommended by American Academy for an immunosuppressed patient for any ring enhancing lesion as considering it as a toxoplasma. So you give toxoplasma treatment and look at the response. Similarly, in the first scan, the case scenario I have discussed in the talk, this patient had a subacute infarct with hemorrhagic transformation, and there is a ring enhancing lesion. So in those situations, actually, since the patient is improving, we could have taken another scan after 6 weeks. So usually 4 to 6 weeks, we will take another scan, because most of the time we would be understanding the lesions which are going to go for an impending herniation. For example, a glioma. So if you see a glioblastoma multiforme, there will be rampant edema and midline shift, and it will look like it is so tight in the brain. So we cannot wait for any more time. But in low-grade glioma or other things, we can actually wait for 4 to 6 weeks. You take another MRI with contrast or another CT with contrast. You can see the lesion size increasing or the overall midline shape is increasing. Then definitely we would go for excision biopsy or stereotactic biopsy. So I think there is a definite role for taking appropriate therapeutic step as well as repeating the imaging. This should be a part of our practice, and this is actually customized. For example, you see the first CT or MRI, you see the lesion that's very aggressive, lot of edema, and there is midline shift. You would be hesitant to go for conservative treatment unless you have some other corroborative evidence. For example, you have a patient with a large lesion with a lot of edema, slight midline compression, and you got endocarditis, or you got a pelvic abscess, you got some subdiaphragmatic abscess or a liver disease or a Klebsiella pneumonia, then okay, you think it is a brain abscess. Then you would give a course of antibiotic therapy and see, like maybe within a week you take another scan with anti-edema measures and antibiotic therapy. But in other situations, it will be, it is highly customized for the patient. So it is in a given context, you would be giving the appropriate step and the treatment. I think we cannot generalize. It is highly physician dependent and depending upon the clinical context. So, but however, generally you would be able to understand whether this lesion is really bad. Like a large glioma with a lot of edema, impending herniation, you straight away go for surgical decompression and biopsy. And if there are multiple small lesions and they are not very dangerous, patient is having minimal headache and all, you may try, you give treatment and then you wait. You give steroids and albendazole, or you give AKT for 2 weeks with steroids and see. But when it is not responding, it could be a fungal one like that. But we would somehow get some clues during the whole clinical picture. So I think it is highly physician dependent, but we'll follow these general guidelines.
Okay, so thank you very much, sir, for this joining this session and enlightening us. So now, since you're running short of time, we'll quickly move on to the next session. Thank you, sir. Thank you, sir.